Thank you for joining us today for ToxTime. My name is Jenny Rodriguez, Account Development Manager with USDTL. Today's presenter is Dr. Joseph Jones, Chief Operating Officer with USDTL. Without further ado, we welcome Dr. Jones.
Thank you, Jenny, and thank everyone for joining us here today for a discussion about environmental exposure drug testing, specifically ChildGuard hair testing. Let us begin. Did you know that children living with parents who have a substance use disorder are 2 times as likely to be hospitalized for somatic illnesses, injury, or psychiatric disorders? Did you also know that in this country, we have approximately 2.1 million children living in a household where at least one parent has an illicit substance use disorder? So what's the problem with this? These environments are environments that are unsafe for children. If you have primary caregivers who are more engaged in drug-seeking behavior instead of taking care of their primary responsibility, raising the child, that sets up a situation where you can have a higher probability of abuse or neglect. And the abuse could be physical, mental, or even sexual. Doesn't mean that every kid is abused or neglected, but the probabilities are somewhat higher. So what this means when we break it down is that in our country, 1 out of 35 kids are living in a dangerous drug-using environment. What does that mean for you? If we take the statistic and break it down to a local classroom, that's almost 1 child in every classroom that may be living in one of these environments. What does that mean? The elementary school down the street from your house that maybe your child went to, is someone in his or her classroom in one of these environments? Does your child visit their home or spend the night? Does that child come to your house? The average elementary school in this country has between 500 and 600 students. So that means in the elementary school right down the street from your house, there could be up to 14 children in that elementary school suffering in plain sight. So what can we do about it? Well, USDTL's vision is to protect and enrich lives. And we're on a mission to make a difference. And we've been doing this for a while. And we got started in this back in the 90s. Hair testing was just getting started. It was just becoming accepted in a lot of different venues. And we had a child protection services manager in a county and a state here in the Midwest. And they called us. They said, we've got a case here that is being difficult. We knew that the child was in a dangerous environment, but the parents were very slippery. They were unable to get them on a positive urine drug test. They knew how to beat it. They knew how to avoid drag their feet. When a hair test was ordered on them, Dad showed up shaved from head to toe. Mom showed up as a platinum bleached blonde and shaved from the neck down. And so thwarted the efforts at that point. So they called our laboratory and they said, we keep hearing this thing about environmental exposure and that it's an issue with hair testing. In this case, do you think that if we got a sample of the child's hair, do you think we would pick up environmental exposure? And we said, well, according to the literature, it should. And so we gave it a try. CPS went to the school, got the child, got a hair collection, sent it to the laboratory. We analyzed it, and we reported it back out as positive for methamphetamine. Talking to the CPS manager, they're like, thank you, we can take it from here. So that first test, the very first ChildGuard, we were able to provide concrete evidence, conclusive evidence that this child was in a dangerous methamphetamine environment. And from there, we've grown from that very first specimen up to between 500 and 600 cases a month now. So before we go on, I would appreciate everybody responding to this poll question. I have two questions. And the first one, and it's just yes or no. Have you ever provided drug testing services in a child custody case? Yes or no? And the second question is, have you ever used ChildGuard or worked with someone who has? If you could please answer yes or no, then we can move on. I'll give you just a second. That'll help me calibrate my presentation going forward. Thank you guys very, very much. So in order to really understand how ChildGuard works and environmental exposure testing works, it would pay for us to circle back and talk about how are drugs incorporated into hair. So drugs are incorporated into hair through three main routes. First and foremost is environmental exposure. If you're in a room where drug is being smoked, handled, distributed, excess particulate matter, that drug will migrate to your hair, get on your hair, work its way into the nooks, crannies, and pores, bind to the proteins and pigments, and then it's available to be harvested and analyzed immediately. Route number two, sweat and oil from the scalp. These fluids contain drug and drug metabolite. This is important. Drug and drug metabolite, similar to urine. And as those fluids bathe the hair shaft, they deposit the drug and drug metabolite. Again, it works its way into the nooks, crannies, and pores, binds to the proteins and pigments, and is available to be harvested. We start seeing that maybe 2 or 3 hours following a dose. Starts to show up. And then route number three, which is what we normally think about with hair testing, is the blood, which contains drug and drug metabolite, deposits drug and drug metabolite into the root. And as that portion of hair emerges past the scalp line, which takes about 2 weeks, it can then be harvested and analyzed. So at the end of the day, we've got three extremely different modes of incorporation superimposed on top of each other. So it's a very complex picture. And so right from the beginning, we are not able to backtrack to determine time, dosage, or frequency. There's just too many variables. Now, hair at average grows at 1/2 inch per month, especially at the back of the head where we collect these specimens at. At the laboratory, we trim that hair to 1.5 inches and we discard the excess. So our detection window is limited with up to approximately 3 months of hair growth. Most drugs stick around a little shorter than 3 months, a little longer than 3 months. 3 months tends to be like a good happy medium for detection. And it has become a de facto standard in our industry. Now, the next question that we get is, can you use fingernails? Fingernails are keratinized proteins, very similar to hair. And yes, you can. You can use nails, but it is less sensitive. One of the variables in hair testing is the pigment. And fingernails generally have little to no pigment. It is also a beta pleated sheet anatomy, as opposed to hair, which is an alpha helical. With the fingernails, you have this one surface on top for the contamination. With hair, you've got 360 degrees around the shaft of the hair. So for a couple of different reasons, hair seems to be a little better, a more sensitive assay for the detection of environmental exposure. So here comes the big question, right? So we get this result back. Was it environmental exposure or was it ingestion? Now, there's a couple of different strategies that different laboratories use to answer this question. The earliest and one that is still in use is called wash kinetics. And what this means is that you wash the hair a certain number of times with a certain buffer, and it will remove the environmental exposure. There's been enough data in the literature to show that that does not work every time. And for that reason, we do not subscribe to that strategy. The strategy that we prefer to use is called metabolic profiling. Big term, simple concept. If we find the drug itself in your hair, that is evidence, it's conclusive evidence of environmental exposure. However, if we find a unique liver-produced metabolite in your hair, then that is evidence that the drug was inside your body and therefore it had to have been ingested. So that's, to me, seems to be a little simpler way to go. And our laboratory, this is our preferred way to interpret these results. So what does this mean when you get a result? We can look at a few examples here. Let's take the most prevalent one, marijuana. If we find THC, THC is the drug that's in the leaf and the smoke. This is what makes you high. If we find that in the hair, that is evidence of environmental exposure. Doesn't mean you didn't use, we just don't have any evidence of that. However, if we find carboxy-THC or THCA, that's a unique liver-produced metabolite. That means it's been inside the body, so it had to have been ingested. So to review, if we find THC in the hair and that's it, environmental exposure. If we find THCA or carboxy-THC in the hair, that's evidence of ingestion. Let's look at another example. Methamphetamine. Methamphetamine is metabolized to amphetamine. The reverse is not true. So if we find methamphetamine in your hair, and that's it, evidence of environmental exposure. If we find methamphetamine and the unique liver-produced metabolite amphetamine, that's evidence of ingestion. You'll also have some cases where people are taking Adderall or Vyvanse, which is pharmaceutical-grade amphetamine. Now, they will only have amphetamine in their hair, not methamphetamine. But it can get tricky. If you need help, call the lab. We'll be glad to help. Another example is hydrocodone and norhydrocodone. If we find hydrocodone in your hair, conclusive evidence of environmental exposure. Norhydrocodone is a unique liver-produced metabolite. Same thing with oxycodone. Drug in your hair, environmental exposure. Noroxycodone, unique liver-produced metabolite. Now you might be thinking, how does someone get oxycodone environmental exposure in your hair? Several of our accounts are medical professional substance abuse monitoring programs, and we've had occasion where we've had pharmacists who are handling these materials without gloves on, and they get contaminated with the oxycodone on their fingernails, in their hair, but the noroxycodone is absent. However, if they are relapsing or diverting to themselves oxycodone, we've had cases on both sides of that. We've been able to demonstrate environmental exposure and ingestion in different cases. So this is very helpful. And now a drug that has been in the press a lot in the past few years, fentanyl. If we find fentanyl, environmental exposure, norfentanyl, a unique liver-produced metabolite, evidence of ingestion. We may see fentanyl as environmental exposure in some cases because if they're smoking cocaine or if they're smoking heroin that's been laced with fentanyl, we may find that in the hair of the child. So this is good information to have. Now, here comes the difficult ones, cocaine to benzoylecgonine. Benzoylecgonine is the primary metabolite found in urine. It's the principal metabolite of cocaine. Unfortunately, not only is it a metabolite, but it's also a natural decomposition product when exposed to moisture at the right pH. And so in this case, benzoylecgonine is not a unique liver-produced metabolite. It can be there from different reasons. So we can't use benzoylecgonine to help us interpret cocaine. Same thing with heroin. Heroin on standing with moisture at the right pH will decompose to 6-mem. So these two are complicated, and this can be the subject of an entire presentation. And so we'll hold off and talk about those in more detail at a later date. If you have one of these results, call the lab. We'll be glad to help you work through it. Now, one of the questions that we get sometimes is, do these tests hold up in court? And the answer is yes. And that's because we follow two of the primary constructs in producing a forensically defensible result. Construct number one is chain of custody. Every specimen at USDTL is collected, received, processed, reported, and even to when we destroy it 1 year later, all of that activity is done under a documented chain of custody. And we can reproduce that data and show exactly who had it, where was it at any given point in time. So that's important, chain of custody. Equally important to chain of custody is confirmation testing. All positive results at USDTL are confirmed by an appropriate mass spectrometric method. That is the gold standard for confirming drug results in a forensic environment, and all positive results are confirmed by mass spectrometry. So taking these two constructs in tandem, these are the cornerstones of generating a forensically defensible result, and this happens on every sample at USDTL. These are two questions that are really important to ask once you get into any kind of drug testing situation. Litigation support can be tricky, and so we're here to help. We can assist you with business record affidavits, letters of interpretation, litigation packages, which are certified true copies of all of the raw data and the chain of custody, both internal and external to USDTL. And we have a team of scientists that are there to help you with expert testimony in case we need to either testify via telephone, video, or on site. We're there to help. So what trends are we seeing at USDTL? In our ChildGuard for 2020, last year, these are the positivity rates that we observed in our ChildGuard. Now, keep in mind, this is not a general U.S. population, general demographic. This is a very select, high-risk population that we're testing. Child custody cases where drugs have been implicated, suspected abuse, neglect. So these are not run-of-the-mill general population results. But as you can see, marijuana is by far the most prevalent and up over 70%. We have methamphetamine at almost 64%, cocaine at 7.7%, and opiates at 1.8%. So on the methamphetamine, something interesting is that over the past decade, the DEA has been reporting that they are seizing more and more methamphetamine at the border. And you can see just how much it has gone up over the past decade. Also, they're reporting that the purity of methamphetamine at the border is going up and that the price is going down. So this is not a good thing. During the same period of time, methamphetamine-related admissions into public treatment facilities has been on a steady increase. And Quest Diagnostics reported in their drug testing index, specifically for hair, general workplace, positive methamp has been going up there as well. So this begged us to ask the question. Now, if you're not familiar with United States Drug Testing Laboratories, one of our significant lines of business is what we call newborn toxicology. We test little babies right after they're born, either using their meconium, which is the first little poo a baby takes, or we get a snippet of their umbilical cord, about 6 inches. And we can do a drug test that reflects maternal usage during the, or in utero exposure during the last half of the pregnancy, approximately. And so when we saw these previous slides, we asked the question, would a similar increase be observed in a national data set of umbilical cord tissue results? And this is what we found. We found that we did indeed see a dramatic increase of methamphetamine over the last decade. And we can see at the beginning of the decade, it was plateauing at almost 3%. At the end of the decade, it's plateauing in the mid 5%. And we had this rapid increase between 2014 and 2017. What's going on there? You know, the news was full of the opiate epidemic, not the methamphetamine epidemic. So what was going on here? This data was reported at the annual conference of the College on Problems of Drug Dependency last June. In preparing for this presentation, I was thinking, would similar increases be observed in a national data set of ChildGuard hair analysis? And so we pulled data for the last couple of years, and lo and behold, we did. It's a very similar pattern. We have kind of a plateau at the beginning of the decade at around 50%, and we're at the upper 60s here in the last few years with this rapid increase between 2016 and 2018. The years are a little different, but it's the same general pattern. Don't know what to make of this, but this can't be a good thing. Methamphetamine is not a good thing for the prevalence of it to be increasing in a population. So to me, this dramatically increases the importance of ChildGuard. And so now on to probably the funnest part of a presentation like this is let's take a look at some real case results, and we can interpret the results, and you can see how you can use these results in your jurisdiction. So let's start with our first case. So this was a program ordered abstinence. So this person was either in like a board of nursing program, a physician health program, airline pilot program, somewhere where it's safety sensitive, and they've been ordered and they've signed a contract to be abstinent and not to associate with known illicit drug users. So the participant had a head hair that was negative for amphetamine and positive for methamphetamine at 7856 picograms per milligram. So interpretation on this is we've got the drug, no metabolite, environmental exposure. But then the toenail and the urine, and frankly, this was several urines, were all negative. So how could that be? Well, urine it will not pick up environmental exposure. And with the toenail, if you're wearing socks and shoes, it's not exposed to the methane as readily. So this story kind of fits. The donor suggested that the significant other was still using methamphetamine, and they asked them to submit to a drug test, and there it was. So now we could deal with the situation. This donor was not obliging to the contract. They were associating with a known methamphetamine user, and I don't know what happened following that because we're kind of cut loose at that point. But at least the caseworker was able to work with that participant with full knowledge that, you know, if you're associating with a known user, that's like the first step to relapse. So it's just not a good idea. So our second case was a pharmacist. This was the pharmacist case I was telling you about, where the head hair had 782 oxycodone, but no metabolite. The fingernail had 256, but the toenail was negative for both oxycodone and noroxycodone. Again, this kind of fits that pattern we're talking about, where the head hair and the fingernail, especially if they're handling the pills with their bare hands and not wearing gloves, but then the toenail is under wraps under a sock and shoe. And so this kind of fit the story there. Now here's a drug court case, and where the drug of choice was marijuana for this particular participant. So we had a head hair at 421, and he also had a carboxy THC at 0.84. So this is consistent with ingestion. They also had a fingernail that was at 1525 THC with 2.54 for the carboxy. Again, consistent with ingestion. And then we had a toenail at 2502 and the metabolite at 9.86. So all three specimens were consistent with the participant continued use of marijuana. But the interesting point I wanted to show you here is that when we have someone that's using a particular drug, we will typically see, like it, especially for marijuana, we will see where the hair is lower than the fingernail and the fingernail is lower than the toenail. And it has to do with the thickness and that the drug is protected by the thicker nail material. The fingernail is like 4 times thicker than that strand of hair. So it's less opportunity to leach out when you're normal daily hygiene. So I thought this was an interesting case for us to take a look at today. Here we have a DCFS investigation where we have a participant's head hair with 1126 and the metabolite at 0.12. So that's consistent with ingestion. We have a 2-month-old with a head hair at 168 for the drug and 0.08 for the metabolite. So ingestion. And we have a 5-year-old that only has the drug at 423, but negative for the metabolite. So here we've got the participant consistent with ingestion. We've got the 5-year-old consistent with environmental exposure. But then we've got this 2-month-old that looks like it could be ingestion. So there's a couple of things. When we got the little kids, we have to be careful with these. So number one, hair goes back 3 months. And so this could have been exposure in utero. Number two, or ingestion in utero. Number two is that the sweat and the oil from the hands of the mother with a little infant and you're holding it all the time, the sweat and the oil can contaminate the child's hair. It's potentially there. So we have to be aware of that. Another thing is that the baby could have been breastfeeding. In this case, the baby was not breastfeeding, so that was not the answer. We knew that the child was exposed because of the 5-year-old. And so the ingestion probably was either in utero or from the sweat and the oil from the hand of the mother. And for the last case study here, this was a child custody case. Mom was accused by dad for using methamphetamine. Mom's head hair was at 1276 amphetamine, methamphetamine at 7856. So this is consistent with mom ingesting methamphetamine over the 3 months prior to the collection of the specimen. We had dad with a classic result for environmental exposure with negative for the metabolite and 1256 for the drug. And then we've got 3 children. We've got a 6-month-old that was negative for the metabolite and methamphetamine at 4500. A 3-year-old negative for the metabolite, 850 for the drug, and then a 15-year-old child that was just negative. So we've got a case here where we've got evidence that mom was using, dad was exposed, and 2 of the 3 children were exposed. Well, what about this 3rd child? What's going on there? And so I put this case in because we see this phenomenon quite a bit. And I call it stair-stepping. And so you will get the highest results for the youngest children, and the results will continually decrease as the children are older in the household. And as the child develops, they tend to migrate farther away from the caregiver, average distance away over time. And so we've got here an arm baby that was positive, and then we've got a 3-year-old who's out and about playing and not necessarily in mom's lap arm all the time. And then we got the 15-year-old who, I don't know, maybe was playing Little League baseball or basketball and just wasn't at the house much. You'll see the results drop down like this. And sometimes, like the older children, will be negative just because they're not around that parent that much. So this brings us to our last case study. And it's almost to the end of our presentation here. And before we close out today, I wanted to take this opportunity to invite each of you to join USDTL in our mission to make a difference, on our mission to protect and enrich lives. And so how can you do this? Well, first, you could visit our website, and the link is at the bottom of the slide here. And clients have told us that they have appreciated the amount of information that we've accumulated there over the years with regard to hair testing in general and ChildGuard testing specifically. And so you're free to review that data, pull it down, use it in your jurisdiction how you see fit. If you see any gaps, let us know, and we'll find additional information and post there. We're adding to it all the time. Second, I also hear from clients that, well, I didn't know you could do that. So take the opportunity to either send us an email or call the number listed below and talk to our client services and go over our catalog or request a catalog. Be happy to tell you all the different panels and profiles that we have. Did you know we have a 19 panel in hair? It's new. If you are a client of USDTL and you've never ordered a ChildGuard, call your account manager and they'll be happy to walk you through and talk you through how to set up ChildGuard and how to order it. And last but not least, if you're not a client of USDTL and you would like to use our services, again, send us an email to the email below or give us a call at the 1-800 number below, and we will be happy to have someone walk you through setting up accounts so that you can send samples to USDTL. And so with that, that comes to the end of my presentation.
Like and subscribe to our channel to receive notifications about new videos.